Welcome everyone to today's webinar. I'm Becky Sanders, Program Director for the Upper Midwest Telehealth Resource Center, and we are so grateful to have Stephanie Laws with us today. I feel like Stephanie and I have grown up together. We've known each other about 10 years, and she's had a lot of change in her life recently, but I'll let her tell you about that. Stephanie, go ahead.
Hi, thank you, Becky, and hello, everybody in the audience. It's a pleasure to be here again presenting to the Upper Midwest Telehealth Resource Center and the fellow constituents that, we have really formed a lot of relationships with over the course of the past almost, 6 years, Becky? Going on 7 years. So that's pretty awesome. Just really briefly, I've been around doing telehealth and invigorating change in rural critical access hospitals and outpatient settings since around 2007. And as Becky alluded to, most recently I accepted the vice presidency role here at Union Health, and I am the administrator at Union Hospital Clinton, which ironically is where I got my start in telehealth and bridging the gap to reduce the geographical barriers to care for patients coming into this facility. So I am really super excited to be able to return to my roots and the home community that is so near and dear to my heart, and to be able to share with you some of our success stories that is relative and pertinent to, I think, all of you as we try to invigorate and integrate telehealth change within our respective organizations. So Becky, if you want to go to the next slide. First and foremost, I'm just going to say I'm going to turn off my video because in my new office I have some illumination issues with the fluorescent lighting. So you're just going to hear my voice, which is not a bad thing for all of you instead of seeing me during this presentation. But I do want to start off by giving a disclosure that the clinical telehealth programs that are represented in this presentation are supported by funding made possible by the Health Resources and Services Administration's Office of Rural Health and its Office for Advancement of Telehealth from the Department of Health and Human Services. Its contents are solely the responsibility of myself as the author, and it does not necessarily represent the official views, opinions of the Department of Health and Human Services. So I just wanted to get that put out there for all of you, and specifically to let you know, again, at the conclusion of this presentation, if there are tools, if there are resources that we can share, these have all largely been developed as a result of grant funding, and through Becky and the Upper Midwest Telehealth Resource Center, we are so happy to be able to share these things so that you don't have to reinvent the wheel. So I just want to start off just by painting a picture, maybe with a broad brush, to talk a little bit about who we are and where we're at. And I still continue, even though in my new role, I'm still continuing on with our telehealth projects here, as well as my role through the Rural Health Innovation Collaborative. So a little bit busy these days, but I do like the dynamic, and for those of you who know me and my energy, it really fits well. So just to take you back, the grant funding that I'm specifically referencing in this specific presentation is a grant that was made possible to the Union Hospital and its Richard G. Lugar Center for Rural Health. The Richard G. Lugar Center for Rural Health has a mission as a department of Union Hospital located in Terre Haute, Indiana, which is a 380-bed acute care multi-specialty health center. It's comprised of primary care and specialty care clinics, as well as one critical access hospital, which is where I'm physically located in Clinton, Indiana. The 9-county service area around and surrounding Union Health is largely rural, very agrarian, and it is very much largely medically underserved and experiences health profession shortage areas. Obviously, you know, this is not unlike any other community that probably our audience is not sitting in right now. So I just wanted to kind of size up the area. But the Richard G. Lugar Center, it's as a department of Union Hospital, I think I might have skipped over that. Its mission is to advance rural health through education, collaboration, and innovation. By the map that you can see on your screen, we are located in the heart of West Central Indiana along the eastern Illinois border. We're just 3 hours east of St. Louis, 3 hours south of Chicago, and 3 hours west of Cincinnati. In 2007, Union Hospital's Lugar Center embarked on its first telehealth endeavor. Thanks to funding from the Indiana State Department of Rural Health by forming a telebehavioral health platform. In that time frame, we had some significant issues due to funding shortfalls where on-site behavioral health specialists were no longer able to come out into the rural critical access hospital emergency department to evaluate patients who were in need of acute behavioral health evaluation and services. And this was creating a lot of efficiency issues, a lot of safety issues for the patients, and it was creating a lot of defensive medicine practices among the physicians who were out in the rural setting. As a result of the seed funding from the state to be able to integrate this telebehavioral health program and bridge the gap between these much needed providers and patients seeking care and treatment in our emergency department and our inpatient units, we were able to immediately reduce that emergency department length of stay, avert unnecessary admissions that were previously inspired by safety reasons and safety causative factors versus medical necessity. So after that, we were able to then replicate that same product through the State Department of Health, and we put that across the critical access hospitals that you see on the left-hand side of your map in West Central Indiana. After that, we identified additional telehealth needs that we were able to further support the success, which was cardiology, and through that momentum, we were able to form what's called the Wabash Valley Rural Telehealth Network. It's what you see there as the title on the bottom of this slide. And we were able to walk into our first federally funded program between 2010 and 2013. And then specifically the one that we will be talking about today, which IRHA, the Indiana Rural Health Association, and its Upper Midwest Telehealth Resource Center has been instrumental in helping us to disseminate information and knowledge about our findings, came in 2014. But just to go forward on the next slide a little bit and continue to talk about the community, I think it's a very important factor for you to understand as we get into the change management and why the community-based needs assessment is such an important factor when it comes to change management. But this is just a snapshot of the West Central Indiana region by county that reveals that our counties rank very poorly, sometimes, you know, near the bottom 10th of the state. For health outcomes and clinical measures. Overall, the population growth rate in this region is flat. We have a significantly aging population. We have poor economic indicators, poor median income levels, high poverty, and not to mention with all of those confounding factors, we have a high prevalence of risk-taking behaviors that do impact our health outcomes and clinical indicators. And the next slide just takes a deeper dive into that. I abstracted out here for you to see that the cardiac disease mortality rate by county. Vermilion County, if you are a man or woman living in Vermilion County, which is where the hospital that I'm sitting at is located, you have obviously a great, much more significant risk of dying from a cardiovascular disease than you do in any other county in the state of Indiana. It ranks the worst out of all of Indiana's 92 counties, and it's almost 3 times more than the state rate and also the U.S. rate. Likewise, with the graph on the right, Vermilion County is significantly higher for stroke mortality comparatively to Vigo. And when we look at Vermilion County, and I'll just give this to you in perspective maybe for those data junkies out there, The overall population for Vermilion County is 15,000. Vigo is just up towards mid 85,000. And we look at these per population density at 100,000 rate. It just shows you that we have some significant health outcome issues within our community. Next slide. So as we look at what was our primary mission, and obviously I touched upon a little bit about how we got some seed funding from the State Department of Health and its Office of Rural Health to be able to pilot some of these telehealth programs back in 2007. And obviously since 2007, we have seen an evolution of technology, medical diagnostic equipment that is integrated in telehealth, but it has just been a complete boom from the technological side of this equation to be able to offer more integrated and standardized pieces of equipment to foster these experiences between providers and patients. And so as I mentioned, in 2010, we received our first federal grant. And that was really largely where we did create the Wabash Valley Rural Telehealth Network. And the reason why we came together there, going back to that map on West Central Indiana and these critical access hospitals, was because we could maximize our economies of scale. We weren't all investing in a singular platform that would run in each of our respective facilities. So when we looked at all of these multiple independent organizations that comprised of critical access hospitals, they were all struggling with some of the same issues that we were here in Clinton. And through the creation of a shared network, we could run contracts between providers and those hospitals independently so that they also had the ability to get these services in based on the needs identified in their areas. And obviously those opportunities to expand specialty health services were quickly identified. And going back to some of the community health needs data that we had applied our knowledge to create our programs, some of the same methodologies was applied here to make sure that we were bridging the gap for these identified needs. And obviously, from an administrative or an executive C-suite perspective, there was the enhancement of telehealth value among the partners. What can we do to create leak reduction, market retention, making sure that we're able to keep the ample volumes that we need to keep in rural? Because when you come back to the economics, critical access hospitals are some of the largest employers in their rural communities, employing on average about 150 well-paid full-time and part-time and PRN benefit-bearing positions. And so the ability to keep that volume at a place where it is economically viable for these critical access hospitals to survive are paramount. And the retention of just 3 cardiac cases or 1 orthopedic case, or the more efficiency we can run because we're doing the right thing for the patient every time, makes such a big deal in those finance and accounting statements for those critical access hospitals. So as we go to the next slide, just to kind of size up for you, as part of this HRSA grant evidence-based tele-emergency network grant program, which we'll dive into a little bit deeper about its objective, it's just important for me to recognize all of the multiple independent recipients of critical access hospitals on that list on the left of your screen, and then the emergency care providers that are on the right. For grant and evaluation management, we've partnered with Indiana State University, and then at the federal level, while not written on this screen, I do need to recognize the University of Iowa and the work that we have been doing at the national level with data aggregation and their group, as well as the Indiana Rural Health Association and the Upper Midwest Telehealth Resource Center for grant information and data dissemination. It's important to share our stories, as you know. On the next slide, I'm just going to give a brief overview about the background of this particular grant that I'm talking about, which is the Evidence-Based Tele-Emergency Network Grant Program. This is a 3-year grant that was awarded in 2014, totaling $1.2 million. But due to multiple variables, we were expanded to 1 additional year, so a 4th year, that will effectively come to an end August of this year of 2018. We are one of 5 U.S. grantees, and the overall emphasis of this grant was to generate a significant number of patient encounters to evaluate patient and provider outcomes and costs of tele-emergency services in rural ERs. Now, some of you who may be coming from rural may say, you know, volume is certainly an issue. And as we dive deeper into this presentation, we're going to learn about how do we compensate for volume as it pertains to competency and confidence in that telehealth space, especially, you know, when we're doing things right there in front of the patient and getting the team around, making sure that there is confidence in that space to pull off a telehealth consult that is consistent every single time. So on the next slide, the outcomes just briefly touched upon was that, you know, ultimately this is a patient-centered approach. We want to facilitate optimal patient health outcomes every single time. This is not something that we embarked upon to replace process. We want to augment process and think of telehealth as a tool. We want to make sure that we're educating emergency care providers regarding telehealth competencies, and that's really important that we always go back to that thought process of those telehealth competencies and also how that is very significant in change management. But ultimately, as I just alluded to earlier about the impact of critical access hospitals in their rural communities, is there any opportunity for the sustainment because we are handling cases in a more efficacious fashion, and also maybe even having some change in disposition pattern after a telehealth consult is provided. So instead of transferring the patient, did we retain the patient? It's also important in this day and age to always look and discover where costs can be neutralized and reduced with telehealth. And just as we are doing today, we're sharing data, we're sharing outcomes and dissemination opportunities with other national sites via our collaborative agreement and activities. So again, just to give you a little bit of background. So it's just really important just to say that end user adoption of telehealth solutions is challenged by the need for the integration of new technologies in the clinical practice environment, as well as the incorporation of workflow processes into daily activities. A sustainable adoption plan requires cultural and behavioral changes for use and reliance on ubiquitous, standardized telehealth technologies. The usability and the ease of access to these technologies are sometimes obstructed by the lack of technology integration, its interoperability, and or standardization. And as the vendor market has come more into the mainstream with some of these open architecture thought processes, we still have a way to go. The ability to apply appropriate change management theories that encompass the cognitive and psychomotor aspects of learning, along with the direct impact on behavioral modification to enhance adoption, is absolutely crucial. I can't overemphasize that more, because if you really want to create a high usability and user-friendly telehealth program that supports long-term sustainability, you have to have those frontline caregivers with that high level of confidence and competence, especially in rural with that low volume, to make sure that we are nailing that subject. So upon completion, I've just listed those learning objectives here that we want you to be able to describe some of the cognitive and psychomotor and behavioral modification concepts that support high-level telehealth adoption. We want you to also be able to describe and replicate some competency-based learning strategies, whether that be clinical protocols or algorithms or inventory guides for evaluating end-user adoption and utility. And we also want you to be able to effectively evaluate methods that we've utilized to look at provider perceptions related to the strengths and opportunities for improvement regarding telehealth programs. So next slide, please. Okay, you got it. Thanks. To this end, the Wabash Valley Rural Telehealth Network created an end-user inventory along with competency-based assessments and clinical workflow algorithms that supported standard metrics for quality of service assessment to evaluate the progress of technology. We spent a lot of time listening to our partners in that first, bar there. We had to understand, based on that community-based need, that I kind of went through with you just very briefly about the West Central Indiana region, to look at perceptive needs of what's leaving their hospital or what they're not able to bridge the gap for getting specialty providers to care for, versus quantifying those needs. And then again, looking at the cost of care for those needs that may be leaving their community. I hope that at this point, it just comes down to good business choices. Even if you're a frontline manager or a frontline nurse or you're a clinical educator, anytime that you can correlate that need of what we think we need versus what we actually need, and then assign that to numbers in terms of looking at what our market's leaking, looking at retention opportunities, what is that value proposition, obviously, but it all leads into strategic development. Because once we have those folks that are in our system and engaged, that would engage our chief financial officers or our lead finance agent in those areas, our chief nursing officer, all of these sound bites go so well with making sure we have that top-down support to make sure that then from the bottom up, we are putting tools in place to help facilitate and stand up those end users and our patients to be successful in these encounters. Obviously, is it feasible? And we're going to talk about this just for a little bit, because it's sometimes very hard to look at feasibility when we look at the numbers of what we would retain if we were able to keep cases in the critical access hospital, versus maybe what if we can't find somebody to be able to provide the service for us in terms of what I want to call the asset, which would be the specialty healthcare provider. Is it an upended equation where we're going to be costing a vendor contract so much to provide maybe 10 services per month? It's hard to recalculate that return on investment. But as Becky can tell you about me, where there's a will, there's a way, and you always have to have your creative hats on to think about, where else can I get these services, or where can I go, maybe with the Indiana Rural Health Association, or looking at some other type of a network to come into that fold to help balance the economies of scale. So on the next slide, I'm going to start talking about how we started to formulate the basis of this. And again, this is really focused on that end user adoption and making sure that we have all of the scripting and the knowledge to be able to translate from the top to the bottom and the bottom to the top about why is it important for us to look at the scope of change, how we create our vision, how we drive commitment, how we establish that infrastructure to foster that change, and then furthermore, how we sustain change. I'm sure Becky shares in my observation, at least early on, as we embark down this telehealth journey together, there are many hospitals, many individuals that I met with on an ongoing basis that shared with me, well, once upon a time, we had tried telehealth, and that cart is now somewhere in a storage closet. Or, once upon a time, we tried telehealth, and the grant ran out, so we didn't continue in the process. Or another scenario was once upon a time we tried telehealth and the volume was low, that basically everybody forgot how to do it. And so then there was that whole change management issue of, well, who's the person that knew how to use the system, right? So it's so important that we go back to and look at how do we implement change regardless of whether technology is involved. And I know that probably a lot of you that's been on this call, and have been on previous calls for the UMTRC, have facilitated electronic health record adoption over the course of the past 5 years, and have implemented other best practice processes to help meet your conditions of participation. The same methodology is the same methodology. It's all change management. It's all making sure that we're not only hitting those cognitive chords, but then we're also looking at the psychomotor. How do we deliver that care? What are those process by process breakdowns in that chain? And then how do we evaluate where do we move going forward? So at Union Hospital Clinton, I had mentioned that we had implemented and I'll just kind of give you a case example, the cardiology program in 2009. That obviously you can see from the Vermilion County data that we have a high cardiovascular risk mortality here in the county, which has not changed since 2009. It's always been the worst performing county in the state. But from a clinical and managerial perspective, we were seeing about 50% of all of our ED transfers that were going to a tertiary care site for chest pain, rule out heart attack, that were what we wanted to classify in those low-risk categories. And so what does a low-risk patient mean? That means a patient that doesn't need to go for cath lab, somebody who's not having something that is, we got to send them right to the cath lab, or maybe this patient needs to go to the cath lab tomorrow. We're talking about patients who would come into the hospital with new onset of chest pain, or had been going on for a while. They didn't have any obvious issues with their EKG, but we knew from the lack of them having maybe a primary care physician, diet, lifestyle, and those modifiable risk factors, that, you know, even though they weren't showing the big one right now, that they probably had occlusions and things going on with their heart that probably needed a cardiology assessment and integration. So these patients would stay here instead of transferring to the larger health system there in Terre Haute, and remain here on telemetry services and be able to get all the evidence-based standard care. And so we put a project team together and identified our key stakeholders. We looked at our costs, we looked at our benefits of the change. We had to engage our leadership, obviously, and show them that on a case-by-case basis, and this course was in 2009, the average cost for retaining this patient at Union Clinton versus sending them to Terre Haute and what our collections were, was a pretty significant piece, especially when you're thinking 50% of the ED volume transfer out to Terre Haute. But why do we want to engage our workforce? Well, number one, these are cases that are very appropriate to manage here. But also, we wanted to make sure that we were putting in systems in place and new tools with the technology to give them the skill sets and the competencies. So therefore, we developed those algorithms. Algorithms from a nursing perspective have always resonated very well. That's how advanced cardiac life support is trained and thought about through algorithmic practice and return demonstration. And so we replicated those algorithms to mimic what our process would be for these particular cases. And again, policies, procedures, everything was there. Competencies, the implementation of super users to provide elbow-to-elbow support, and especially among those workforce that were kind of on that as-needed or PRN pool, to make sure that if they didn't work that often, that there was always that support system, which we enlisted our house supervision staff to be able to provide that elbow-to-elbow support. We also looked at reward systems, you know, how many consults did nurse A versus nurse B do? How could we provide that recognition? And like everything, positive reinforcement. Thinking about how we were doing in this case and scenario, not very many nurses had ever listened to the 5 cardiac assessment points, so making sure we were doing that cognitive aspect of re-educating all of those listening points, as well as how to listen to carotids. We did not only the cognitive piece, but we also did psychomotor demonstrations. And we also had tools that we provided for the staff so that way when they were moving the stethoscope for the cardiologist, that they had that level of confidence that if he said, move this to a specific area referenced by that anatomy, then they knew exactly where to go. And from that, then we did competencies, and we had check sheets that went into the employees' HR files, which has continued on today. And I'm not sure if many of you or any of you have certain accreditations. Maybe it's through you know, Primary Stroke Center or HFAP Stroke Ready designation. But if you do have tele services for these cases, then we need to make sure that we're showing not only biannual education around these teleservices, but making sure that they're at least occurring on an annual basis. So the next slide just goes back to knowing what we should all know about project management basics. Going back, and so this picture shows the thought process that somebody had to put an emergency telephone to make them available on the wall of this hospital, not the one I'm at, but this hospital in this picture, so that folks could get on the phone and let them know that an emergency is occurring, or to let them into the emergency department. But somehow or another, it got placed too high on the wall where the patient couldn't reach it. Sometimes the most well thought out and intended projects sometimes come away with flaws. And I have to tell you that not everything that we have done here within the Wabash Valley Rural Telehealth Network has been successful. We learn as much from our failures as we do our successes, because when we have those failures, we have to go back to the drawing board. We make sure that we're looking at our existing clinical workflows. And that was probably one of the biggest lessons that I think I could ever say, is that you have to consider that this telehealth modality is exactly what it is. It is a tool. It doesn't replace your clinical workflow for the workup or the care of the chest pain patient. It doesn't create a different workflow for the workup or the neurology patient who may come in with sudden onset of dizziness or stroke-like symptoms. It doesn't change the workflow for a patient who's coming in with an acute behavioral health need. What you have to do is look at what the protocols are for handling these cases wherever you want to implement telehealth, whether that be in an ambulatory care setting, a clinic setting, a school-based setting, or a hospital setting. It just goes back to those initial measures to look at where does telehealth plug into the process. And that process for us was bridging the gap for a consultative need to help support our rural physicians, whether that be in the ED or whether that be ED meaning emergency department, or whether that be in our inpatient care process. And so when you can translate that back to your staff, that this is step 8 in your decision tree, in your clinical algorithm, in your clinical workflow process for how we treat certain types of patients, it becomes less invasive in terms of having a separate, oh, well, that's a telehealth case. So no, it's just like a stethoscope or an otoscope. It is workflow integrated. The other thing that we did to help gain buy-in and support and overall longevity of our system was that we looked at existing referral patterns. So when we had specific needs as it pertained to bridging specialty care gaps for our critical access hospitals, we went to the folks where they were getting the services before and then helped to integrate tele into the practice so that they could maximize their economies of scale. Because obviously when you think about a cardiologist and I'll call it windshield time or that drive time out to the critical access hospital plus the rounding time and social time, that really gets into that that quality work-life balance for that provider. And so by bringing them along and helping them see how telehealth can help improve that, we were able to really maximize our referral patterns here in the Wabash Valley to not have to go to third-party vendors. But I will tell you, we have had to work with third-party vendors just because there are shortages of certain rural providers, and that is even encroaching on urban areas as well. And so when I talk about the integrated process performance and the clinical workflow processes, just to kind of give you an example of our stroke or our teleneurology program, we have implemented a rapid identification process. So for example, at Union Hospital Clinton, if we have a patient that's coming in via emergency medical services and the paramedics or the EMTs are bringing them in, we have what's called a code stroke. And if those patients have signs and symptoms of stroke, they are calling the emergency department. We are doing stat registration so that if those patients are stable, we are not going and boarding in a room and going through the triage and doing all those things. We're going straight to the CAT scan to get the gold standard and making sure we're getting that CAT scan as rapidly as possible. And now that there are new evidence practices out there around large vessel obstruction and getting those CTAs or those CAT scan angiograms, we're looking at how can we expedite evacuation from rural to get them to interventionalists for a thrombectomy. But it also helps us to look at that clinical workflow process of, okay, this is a patient, this is what we have identified from the CAT scans, and then we get our teleneurologist involved, and they support the consultation to the ER physician and say, yes, I would recommend TPA or the clot busting medication in this case. And so that has all allowed us to decrease our door to needle times, as they call it, for expediting this patient's care. And so again, in this clinical workflow practice, telehealth only became a tool. It didn't start our clinical workflow design. The patient-centered approach was the first and foremost on all of our minds. And so as we train that up, we look at that clinical workflow competency, we look at that algorithm for clinical decision touch points, and then we also make sure that the competency surrounding the operation of the cart, or if it's an iPad or whatever the modality is in your case, is that they have a solid understanding of how to operate, troubleshoot, and overcome simple challenges or barriers that may exist that will also provide them confidence and competence within the clinical workflow. If you go to the next slide, as part of our early work, and you see two examples of some paperwork here, but the one thing I think that we all do resonate to, even though we have adopted electronic health records within our clinical spaces, for the most part, staff still thrive on checklists. So again, if it's something that is not happening very often, maybe you have less than 5 a month, maybe you have 6 a month, maybe you have 2 a month. It all depends on what your specific scenarios look like. But if you have a checklist and they know where to go get that tool that just jogs their memory, it's very much preferred to have at least that cheat sheet tool for them to pick up and say, okay, for a consult, I do this, I do this, I do this, I do this. Making sure that you have important numbers, troubleshooting numbers, help desk guides, anything that you can provide that would be at the fingertips for these providers or for the end user staff, making sure all those tools are intact. Looking at policies, looking at procedures, looking at algorithms, timeline, streamlined implementation. Just get all that again, overemphasize, streamline that into the cognitive piece. And then we have the psychomotor piece of where we actually have the operational evaluation. And I can honestly tell you that, again, in rural and looking at this in a volume-related matter, now we do a lot more behavioral health than we do neuro or cardiac, but making sure that we're at least touching base with the psychomotor competencies at least every 6 months and no less than an annual basis. And so, again, those easy-to-use checklists, those clinical workflow algorithms, making sure that it's at, grab distance, making sure it's easy to find, making sure you have numbers posted on your telehealth modality, making sure that you have those pieces in place is very, very, very important to assure that we have those stand-up pieces ready to support the staff. So on the next slide, this is just kind of a change diagram that looks at, we want to make sure that the employees are ready for change. And employees, I mean, that could be your ER contract physician providers, because if you have an ER provider, physician that doesn't believe in getting consults for neurology services, then the telehealth isn't necessarily an issue. It's more of the conversation and that cognitive piece and the understanding and the expectation of the health system on what the performance around stroke care will be. So again, I think that sometimes we replace telehealth as, you know, the main topic of the conversation, when in fact, you know, it really is the tool, but we have to support our staff to make sure that we understand what are the barriers, what are the challenges, are our patients accepting of it. But then you have to make sure that once you go for it, that when you execute the intended change, that it becomes permanent. So often in healthcare, regardless if it's telehealth or whether it's a strategic plan or whether it's a customer experience initiative or some other endeavor, sometimes we have lack of sustainability, that this modality for telehealth is no different. Okay, we came, we implemented, we put all of this effort behind it, and 6 months later, who's heard of it? I think we all have to appreciate that with everything that you do, you have to have intentional design. You have to have traction, you have to have teeth, and you have to make sure that you're going after it to measure it in such a way that it is meaningful for all. So on the next slide, this grant that I referred to earlier, the evidence-based telehealth resource or evidence-based tele-emergency network grant program, we created a pretty in-depth end-user inventory, which was a survey, and we'll talk about that here in just a few minutes, along with that competency-based assessment, again, that clinical workflow algorithm that set that standard metric for quality and service assessment technology. But across, I think we're up to, you know, however many we listed there on the slide of our collaborating partners, we wanted to make sure that our study was conducted to determine baseline perceptions. What was the competency level and utilization of the telehealth application? What was the educational preparation and access to continuing education in telehealth? We wanted to look at the overall number of clinical experiences with telehealth. Patient health outcomes, we're also evaluating that. And how did the telehealth visit influence the attending provider or their physician in regard to their clinical decision making? And we also request healthcare provider comments. But then we go back each year to make sure that the telehealth is in fact meeting the needs of the dynamic. So again, this is all a plan, do, check, act, as you see for continual improvement on your slide on the screen now, that we're always listening, again, going back to the other part, listening to our partners, listening to the staff, listening to the patient, and listening to the provider, because we certainly have to make sure that if we're not in that organizational dynamic and we're just leaving it as a stagnant thing that we put into the health system, we're not going to be very successful in our endeavor. We have to keep going back. So as you flip to the next slide, I'm going to give you an example of a survey that we complete after each telehealth encounter. This is completed by the end user, this is completed by the provider, and this is also completed by the patient. And in this specific summary, it's relevant telehealth experience among behavioral health patients and providers. So this isn't the end user, but this is some patient perceptions. I just wanted to show you that there's the questions 1 through 7 that we ask about how would you rate your overall telehealth experience today? How well were the procedures explained to you? And so again, this is done on every single encounter. And there in that column, just one off from the right, you can see how many responses this is comprised of and how many 4s and 5s we're getting and where those opportunities exist. But again, this is one way that we're measuring how our competency-based and our confidence bases among our end user staff that are introducing telehealth as a tool within our clinical processes. Of significant importance, I want to draw your attention down to a couple of the provider questions that we have about it was my intention to transfer the patient prior to telehealth consultation, or the telehealth process influenced patient disposition and transfer. And as you can see from 79 survey responses, in that 4 and 5 category, now we do have some good, we have a lot of 3s written in there, but we are seeing a statistical significance in how telehealth is definitely going and changing providers' perceptions on how they disposition patients. And so if you flip to the next slide, I drill down on those two provider influence questions just a little bit more and look at specifically around behavioral health and how the 4s and 5s comprise 61.8% on how telehealth influenced the decision of the provider to transfer or send them home. So that is just an example of, again, that plan, do, check, act, and we use these surveys and their pen and pencil at this time. I mean, we do have aspirations to go to electronic, but for the purposes of our study, we've been collecting these from our multiple independent critical access hospital sites to be able to evaluate the ability for telehealth to make an impact. Again, along with this study, and I didn't go into that today, but it was, we're looking at cost, we're looking at overall ED efficiencies as well. But when we look at change and we look at change management and we look at the cognitive, psychomotor, and then those sustainable changes that you see in the telehealth environment, significant conclusions draw itself upon our 4-year experiences to say telehealth is integrated into existing clinical workflow dynamics. We work with the people, the patients, the providers are most important to listen to at all times. We actually made a change to our telehealth application based on survey results. We had high unreliability with our carts, which caused disengagement and discontentment among our end users and our providers and was not well received among our patients, to the point now where we're on a web-based application and have more upward mobility with an iPad in certain instances. And I'm going to have Becky slide to the next slide. And in conclusion, you know, as always, you know, I am more than happy to share any of my experiences or anything that we can do in durable materials, our survey, what were the results, or to go into and slice and dice specific clinical flow processes, or talk about the challenges that you've had in your clinical spaces to be able to help provide maybe some consultation or some solutions to help get past that hump of integrating telehealth to maximize its impact in a rural setting. And that's all I've got, Becky.
All right. Well, thank you so much, Stephanie. I really appreciate your time today. So now we're going to open up for questions from the audience. You can go ahead and use your chat function, or I'm sorry, the Q&A function there, and go ahead and type your questions in, and then we will answer those. Looking to see there. We don't have any questions just yet. So Stephanie, I was hoping that you would bring up the whole change from the carts to the iPads and how that helped with the telehealth solutions. Is there anything else that you can tell us since you've made that change? Do you have any of the provider disposition data prior to making that change to compare to after making that change?
Yeah, so we had our, again, our standardized survey has been in place for, I would say, almost going on 10 years now. So we adapted the evaluation as part of the evidence-based tele-emergency network grant program. And once we started collecting data, and, you know, I did mention that the technologies have significantly evolved since 2008. We saw from our survey collection a lot of connectivity failure. We saw a lot of what you want to call pixelation, kind of when your screen freezes. Sometimes there was audio disruption versus visual disruption. We were able to collect a lot of good information from our surveys across the entire network. It wasn't just one isolated site that had bandwidth-related issues. It was significant enough for us to go and then conduct a focus group assessment based on our evaluations and our survey results to identify new modalities for us to trial. And so, Becky, you can probably share better than I can with the group as you look at technical aspects of telehealth and look at all of the different modalities and applications that are available out there through the vendor world. We took down a few, and we started looking at not only the endpoint delivery devices. I mean, we went through Surface Pros, laptops, iPads, Defender cases, what was the most durable, because when you think about putting it into a patient space, you got to keep it safe. And our carts were fairly, stagnant in that, they wheeled them in and plugged them in and those things. So we did a lot of significant focus group assessment with our end users about what they wanted to trial. And so we aimed small, missed small, and started integrating the iPad technology, which is what our end users identified was their preferred method. And now we're seeing so much better responses. I mean, overwhelmingly positive responses among our end users about how happy they are. And really, with our new platform, it's a no-brainer. And I used to get called for troubleshooting matters. I don't get called anymore because it's that consistently effective, and it's just very reliable. Mm-hmm. So we just continue to monitor, and then this is also a proactive way for us to identify, if a patient had an issue or a provider had an issue or an end user had an issue, is it a one-off or is it more of a systemic network thing?
Yep. Awesome. Well, thank you. I am not seeing any questions in the Q&A, which must mean you explained everything perfectly and there are no questions.
Sure. And I've been hearing everybody's results, and I just want to encourage the group that if they have any specific needs, to please reach out to Becky. She has me directly within her site to be able to get you any tools or assessments or anything that you can need that you feel like would help. But I think sometimes we just overthink the obvious of how we integrate telehealth as a tool, making sure that we're just following the basic sciences of project management.
Mm-hmm. Yeah, absolutely. In the chat, I have put a link to our webinar satisfaction survey. If you would just take a moment to complete that before you log out today. Always, if there's a place in there for comments, if there's a specific topic you would like us to track a speaker down, please let us know so we can include that in a future webinar.
Awesome. Well, thank you everybody for joining us, and thank you, Becky, for having me.
Oh, you're very welcome. Thank you for taking time out of your busy day.
All right. Well, thank you.
Okay. Take care.
Bye-bye.
Bye.